This conference will now be recorded.
ఎందుకు 60 వెంకీ జేపీ వెంకీ జేపీ ఇదేది రాజేష్ మైక్ లాంటిది ఏం లేదు అది ఇదేనా సరే ఓకే వెంకీ జేపీ సుజిత్
సార్ చెప్పండి.
జేపీ వినిపిస్తుందా?
వినిపిస్తుంది సార్, వినిపిస్తుంది సార్.
ఓకే, అందరు వచ్చేసినట్టేనా? కెన్ ఐ స్టార్ట్?
ఒక 2 minutes సార్, అంటే 100 members వచ్చారు. ఒక 2 minutes తర్వాత.
ఓకే ఓకే JP. JP, now can I start now?
Start change, sir.
Okay. So now coming to the paralysis of the larynx now. So you should know the nerve supply before going to the paralysis of the vocal cords or vocal cord paralysis. So before going that, see, remember that these are you able to see the screen which I'm scrolling up and down the pictures?
Yes, sir.
Okay, the fine. Now coming to the nerve supply of larynx. See, nerve supply of larynx, you see in the it is divided into motor and sensory. Okay, it's divided into motor and sensory. When the motor is recurrent laryngeal nerve is the major supplier, which is a branch of vagus, which supplies all the muscles except the cricothyroid, which is supplied by the external branch of superior laryngeal nerve, which is also a branch of vagus nerve. Okay, it's an external branch of superior laryngeal nerve. So if you can see here, this is the jugular foramen from which the vagus nerve arises. There is a superior ganglion here. There is an inferior ganglion here. You can see the vagus here. This is the vagus nerve, and this is the superior laryngeal nerve. You can see that it is branching into two. This will become the internal branch. This will become the external branch. Here is the cricothyroid muscle. So all muscles of larynx are supplied by the recurrent laryngeal nerve, which is nothing but a branch of vagus nerve, except the external branch of except the cricothyroid, which is supplied by the external branch of superior laryngeal nerve. So now again, let me make myself clear. So this is superior ganglion of vagus, inferior ganglion of vagus. This is the vagus, and this is the jugular foramen from which the vagus now comes out. So now the vagus now here gives rise to the recurrent laryngeal nerve. This is the recurrent laryngeal nerve. Here it takes here you see in the left side the course is different for the recurrent laryngeal nerve. In the right side the course is different for the recurrent laryngeal nerve. Here in the right side, if you see the recurrent laryngeal nerve takes a it loops around the subclavian artery, whereas if you see it takes a loop around the arch of aorta. So left recurrent laryngeal nerve has a more what has a more longer course, so it's more prone to injury. So remember that whenever you ask which nerve is injured more, I mean which side of the nerve is injured more, the left recurrent laryngeal nerve is more injured because of the longer course and the longer duration. I mean, sorry, the longer course. Okay. So now you see the vagus nerve giving rise to the recurrent laryngeal nerve over here, whereas in the right side here. So this is the vagus nerve branch, the recurrent laryngeal nerve, which is given here. Now, whereas you come to the superior laryngeal nerve. This is the superior laryngeal nerve. See, this is the superior laryngeal nerve here. It gives superior laryngeal nerve is giving two branches here. One penetrates the thyro. This is the thyroid. This is the hyoid. So thyrohyoid membrane. It is penetrating the thyrohyoid membrane and going inside it. Okay. Whereas this does not. This is the external branch. This is the internal branch. The external branch supplies the cricothyroid muscle, which is also an interesting muscle of the larynx here. Now, if you see the muscles of larynx here, you should know the adductors and the abductors. Adductors is the mnemonic is add tal, that is adductors. You have the tal. So adductor, thyroarytenoid, transverse arytenoid. Transverse arytenoid is also known as intra-arytenoid. Remember that. Lateral cricoarytenoid, cricothyroid. This muscle alone, the all okay, and what is the abductor? Only one abductor we have is the posterior cricoarytenoid. So all these muscles up to here, if you see all these muscles up to here, except cricothyroid is supplied by the recurrent laryngeal, whereas the cricothyroid is supplied by the, remember this is the mnemonic here, CTES, cricothyroid external branch of superior laryngeal nerve. That is how it is. Okay. So you have to remember that. So these are important MCQs also. Only two mnemonics you have to remember. One is add tal. You remember all the adductors, and one is posterior cricoarytenoid, which is an abductor. And CTES, if you remember, cricothyroid is external branch of superior laryngeal nerve. So there have been many times these questions will be repeated. Which is what muscle supply, what nerve supplies the cricothyroid? Cricothyroid is supplied by the external branch of superior laryngeal nerve. I showed you in the diagram. This is the external branch of superior laryngeal nerve supplying the cricothyroid, whereas other muscles are, see, Even you can see the cricothyroid muscle is placed externally. So that is why the external branch is getting, supplies the cricothyroid, whereas the internal branch supplies the this superior laryngeal internal branch supplies the gives the sensation of the vocal cords, gives sensation to the vocal above the sensation of the larynx above the vocal cords. Remember that. See, so now let me make myself clear again. Recurrent laryngeal provides supply to the motor supply to all of the internal portion of larynx except the cricothyroid, and the other function of recurrent laryngeal is below the vocal cords. The sensation of the larynx is given by the recurrent laryngeal. So the recurrent laryngeal has a dual supply. One, it provides the motor supply to all the muscles of larynx except the cricothyroid. One. Second, below the vocal cord it gives supply the it supplies for it gives sensation below the vocal cords, whereas the above the vocal cord the sensation is given by the internal branch of the superior laryngeal nerve, and the external branch of the superior laryngeal nerve gives gives supply to the motor cricothyroid muscle. So now on the whole, this is what I've written here. On the whole, if you see here, this is see the nerve supply of larynx, motor, okay, motor supply, recurrent laryngeal nerve, all other muscles, okay, except branch external branch of superior laryngeal nerve is provided by the cricothyroid. So this covers the motor branch of all the muscles of larynx. Whereas coming to the sensation is very easy. Above the vocal cords, internal branch of superior laryngeal, you saw that this one is piercing, so above there will be vocal cords here, around here. So above the vocal cords the internal branch of superior laryngeal supplies, whereas the below the vocal cords it is the recurrent laryngeal which supplies. So remember that, because as you go on you need to know this, unless you don't understand this there is no point in going forward also. So below vocal cords recurrent laryngeal, above vocal cords internal branches superior laryngeal, okay. So now coming to the recurrent laryngeal course, as I told you, see, this is the right vagus nerve, this is the left vagus nerve. As you can see, the recurrent laryngeal arising in the right side below the subclavian, whereas on the left side it arches around it, it is given it arises from the arch of aorta. So it has a longer course. So let me read this out for you. Right recurrent laryngeal nerve arises from the vagus at the left of subclavian artery, hooks around it, and then ascends between the trachea and the esophagus. Obviously this is the trachea, behind will be the esophagus, so it runs up like this between the tracheo-esophageal groove. So this is the trachea. Obviously posterior will be there will be trachea which you can't see. So it is in the laterally it is there. So this is the tracheo-esophageal groove. So it is running between the tracheo-esophageal groove. The left recurrent, whereas the left recurrent now you can see it arises from the vagus in the mediastinum at the level of the arch of aorta. So and ascends into the neck in the tracheo-esophageal groove. The same thing, once the it arises differently, but the course is similarly is similar. It ascends up in the tracheo-esophageal groove. Thus left recurrent nerve has a much longer course, which makes it more prone to paralysis compared to the right one, because it has more longer course, so it has more risk of injury. So remember that which now out of the two sides, which recurrent nerve is more injured is the left side, the left one. Now coming to superior laryngeal, which again I gave you an introduction of superior laryngeal. I told you this is the jugular foramen which arises. This is the one which arises from the this vagus nerve arises from the jugular foramen, which is nothing but this is the skull base where it comes out. Okay, the jugular foramen. Now the inferior ganglion, you have the superior ganglion. Then you have the vagus nerve. That's what I told you. This is the vagus nerve, and this is the superior laryngeal nerve here. It is given at the see you can see this is the hyoid bone. It is dividing into internal branch and the external branch. I told you internal branch provides the sensation above the vocal cords, whereas the external branch gives the motor supply to the cricothyroid. Let us read this out. It arises from the inferior ganglion of the vagus, descends behind the internal carotid artery, and at the level of greater cornu. See, this is the greater cornu. So it is dividing little below the here. So some people it might vary. The branching pattern may vary. So at the level of greater cornu of hyoid bone, it divides into external and internal branches. The external branch supplies the cricothyroid muscle, while the internal branch pierces the thyroid membrane and supplies the sensory innervation to the larynx and the hypopharynx. So this pierces the thyroid. This is the hyoid. This is the thyroid. So thyrohyoid membrane pierces. Sensation of it gives sensation above the vocal cords, and behind will be the hypopharynx. So it provides the supply to the larynx and the hypopharynx, whereas the external branch gives a motor supply to the cricothyroid. you should remember that this is the only this is the only intrinsic muscle which is supplied by the external branch of superior laryngeal nerve. So that completes the superior laryngeal nerve also. Now the classification of laryngeal paralysis. Actually, now that this vagus now arises from the medulla oblongata in the nucleus ambiguous. Okay, so this is the nucleus ambiguous which arises from the medulla oblongata. This is where the vagus now arises. See, you can see this is where the and you can see this is the jugular foramen, and you can see these, there are three now, you can see the spinal axis now, which is nothing but the 11th cranial now, right? Spinal axis. So here, so whenever you remember that whenever there is involvement of the jugular foramen, even the spinal axis now is also involved. So there will be difficulty in straightening of shoulders. You should have read. You should know that the spinal axis supplies the trapezius and the sternocleidomastoid. So when anything involving the jugular foramen involving the vagus nerve will also involve the spinal axis. See, this is the jugular foramen where the spinal axis is coming out, and here is the vagus nerve coming out. Okay, so now you can see, as you can see, the nerve is starting from here. This is the nucleus. So it can either it can involve the nucleus or the supranuclear part, where it see, for example, above here will be the auditory, the cerebral cortex, right? So anything above anything involving the medulla other than the nuclei, it is called supranuclear. So let us say a stroke involving the brain will also involve the vagus nerve. It might also infect the involve the affect the vagus nerve also. So it might be divided into, see, the laryngeal paralysis causes may be divided to supranuclear, that is this is the nuclear. So above nuclear you have the cortex. So any general involve, let us say a stroke involving the cerebral cortex will also might involve the 10th nerve. So that is the vagus nerve. The nuclear, so nuclear, this is the nuclear. What are the causes which involve the nuclear nucleus of the vagus nerve? So you can see it, any vascular process, let us vascular process, any polio, let us say cancerous lesions of the nucleus ambiguous, the medulla, might involve the vagus nerve also. Okay, now high vagal, at the high vagal means this, the lesion at the jugular foramen. This is called high vagal lesion. So high vagal is at the exit of jugular foramen. Low vagal is that is at the branching of the, this is the low vagal. Once low vagal means once outside. So once outside, this will all be low vagal. So up to here it will be, so it is divided into, one is supranuclear, nuclear, and high vagal. So this is the vagus, high vagal. Whereas here it becomes the low vagal. Any injury here, it will become the low vagal injuries. Okay. So low vagal. What are the other causes? Systemic causes. Diabetes, syphilis, typhoid, lead poisoning can also affect the vagus nerve. Whereas 30% of the times it may be idiopathic. We don't know what's the cause of the recurrent laryngeal palsy. Now coming to you again, recurrent laryngeal palsy can be divided into unilateral and bilateral. So remember that recurrent laryngeal now can be unilateral. Now let us say unilateral. So what happens in unilateral? Let us say you are doing an intrinsic right. Let us say we are doing a hemithyroidectomy. We are doing a thyroid surgery in case of left lobe of thyroid. So when you know that left recurrent laryngeal has a longer course, whenever there is injury, whenever you're operating, if there's an injury, there might be unilateral recurrent laryngeal paralysis. So unilateral see, so what happens in unilateral recurrent laryngeal paralysis? So except the intrinsic muscles, except the cricothyroid, all the muscles are affected. So what is cricothyroid? Now I'll just show you. Cricothyroid is the what cricothyroid is an adductor. Remember that in ad talc I told you cricothyroid is an adductor, right? So cricothyroid is an adductor. If you know that. So what happens? What happens to the vocal cords now? Since see, recurrent laryngeal, I told you it supplies all the muscles except the there is involvement of both adductor and abductor, except cricothyroid, which is supplied by the superior laryngeal. That's the external branch of superior laryngeal. So now what happens to the vocal cord? Remember that the recurrent laryngeal supplies both the adductor and abductor, right? So except the cricothyroid, which is an adductor, you keep that aside. So both the adduction and abduction should be affected, right? But why? So in a recurrent laryngeal paralysis, the vocal cord lies either in a median or a paramedian. So normal is intermediate. That is, see, normal function. Normally vocal cord is in this intermediate position, from which from which it can get adducted or it can get abducted. So this is the normal position. But you see that in a unilateral recurrent laryngeal nerve paralysis, the vocal cord of the affected side, which is this is the left side. Let us say this is the affected side. So left side, it will be either in a median or in a paramedian position. So why this is in the median or paramedian? Because both are affected. It should be why is it only in the adducted position, not in abducted position? Because both the muscles are affected. You should you should get it out why it is not in abducted position, because why it is in adducted position, because both are supplied, but only why it is in adducted position. You remember that there are theories why these are in median and paramedian in case of unilateral recurrent angioplasty. One is the Siemens law. Siemens law states that abductor fibers, that is abductor, what are the abductor fibers? That is the posterior cricoarytenoid, which is also supplied to the recurrent angina. Abductor fibers are the newer ones, and are so phylogenetically they are newer, so they are more susceptible. Thus, so when there is a recurrent angina paralysis, the first one is affected is the posterior cricoarytenoid, so there is abduction is lost, so the vocal cord is in the median or paramedian position. That's what Siemens law says. Whereas the Wagner-Grossman hypothesis, which is more apt, this is the best theory. It says that the cricothyroid muscle, which is the part of adductor muscle, it has an intact nerve supply from the external branch of superior laryngeal nerve is an adductor. So it keeps the vocal cord of the affected side in an adducted position. That is why. So there are two theories. Now you understood. So recurrent laryngeal nerve paralysis, what happens? Recurrent laryngeal paralysis. Remember that you have to remember that in recurrent laryngeal nerve paralysis, that is unilaterally, the vocal cord lies in a median or a paramedian. So when you go to the anatomy, recurrent laryngeal nerve supplies both the adductors and the abductors. But why only the adductors? Why it is an adducted position rather than in abducted position is explained by the Siemens law and Wagner-Grossman. According to Siemens law, it says that abductors are affected first, then followed by the adductor. So that is why, since abduction is lost, it will be in adducted position. Whereas the Wagner-Grossman states that cricothyroid muscle out of the talc muscles out of the adductor, which is supplied by the external branch of superior laryngeal nerve, is intact. So thereby that is why the reason why the vocal cord of the affected is in the median or paramedian, because that's an adductor which is intact. That is a cricothyroid which is intact. So once you because these are both are 2 marks, even if I set a paper, I'll definitely go for Wagner-Grossman hypothesis or Siemens law. Remember, Siemens law have been asked very many times. Last time, even the second entrance, they've asked for Siemens law just as 2 marks. So you have to remember from where it is. Just they'll give you a Siemens law. They won't explain it from the larynx and all. So you should know a Siemens law is from explains the unilateral laryngeal nerve paralysis, why it is in the median or paramedian position. Okay, next. So now coming to the etiology of recurrent laryngeal nerve paralysis, left side, we'll see the left side, which is the more common side, which is the more, so neck, if you see the neck, accidental trauma, let us say any penetrating injuries or road traffic accidents where there is the left side of the neck hits the steering, or in any any attack by an intruder, so piercing the left side of the neck. I told you penetrating the neck, the penetrating the neck, there will be, if it reaches the platysma, when I spoke about the trauma, laryngeal trauma. So remember that accidental trauma, thyroid disease, benign or malignant, involving the recurrent laryngeal nerve. Any thyroid disease means it might be malignant also involving the recurrent laryngeal nerve. Thyroid surgery, as I told you, it has a longer course of thyroid surgery involving the left. If you're not able to identify the recurrent laryngeal nerve correctly, you have to preserve the recurrent laryngeal nerve while doing the hemithyroidectomy. If you don't preserve it, there might be an injury to the recurrent laryngeal nerve leading to a recurrent laryngeal nerve paralysis. So cervical lymphanopathy, in case of let us say there are a lot of diseases which causes let us say Kawasaki disease, where there is an infectious mononucleus, all infects the lymph node, right? When there is a large lymphadenopathy pressing on the left recurrent laryngeal nerve, might also lead to the recurrent laryngeal nerve paralysis, which might be temporary in some cases, but some cases it might be permanent. So you have to remember that. So next, any bronchogenic, because it has a longer course, it extends into the mediastinum. So bronchogenic cancer, carcinoma of thoracic esophagus, aortic aneurysm, mediastinal lymphadenopathy, enlarged left auricle, sear, all these, because it is looping around the aorta. Any arch of any lesions involving the aorta, That's why aortic aneurysms, all these idiopathic, all these can cause the this can cause the recurrent laminal paralysis. Whereas in case of the right side, so again neck trauma is common. Again, thyroid surgery, cervical lymphanopathy cast. Whereas you see this side, right side, aneurysm of the subclavian artery rather than the aneurysm of the aorta. So next, tuberculosis cervical pleura, because it has a shorter course. So and carcinoma apex of right lung. So all these are the causes. Whereas both, it is generally, remember it, when both the nerves are both the nerves are affected, it's most commonly iatrogenic. That is caused by a doctor. I mean, caused by a surgeon, particularly when doing a thyroid surgery. In case of malignancy, where it has been affected, where the thyroid, I mean, the malignancy has involved both the nerves, well, or where the surgeon has been negligent to not to preserve the nerve, where he cuts the sections of the both the recurrent laryngum when he is not able to identify the recurrent laryngum. So remember that. So it is more commonly, when both is involved, it's more commonly iatrogenic. Now coming to the clinical features. So most of one-third of the unilateral laryngeal paralysis patients are asymptomatic. There might be a slight change in the voice, but it is asymptomatic most commonly. And why it is asymptomatic? Because you can see that due to the compensation by the other vocal cords. I'll show you here in this picture. See, I told you unilateral recurrent laryngal paralysis might be what to say, it may be in the median or the paramedian position, right? So this vocal cord over a period of time will see to it that it crosses the midline and meets the vocal cord, so that there won't be any symptoms unless you take an endoscope and put it through in the mouth, and you notice it. So one-third of the people will be asymptomatic, and there might be a light change in voice. The voice in unilateral paralysis gradually improves due to compensation by the healthy vocal cord, which crosses the midline to meet the paralyzed cord. So what is the, I mean, what you do in the case of, let us say, you need to wait and watch for 6 to 12 months, then you can do a laryngoplasty type 1. What is laryngoplasty type 1? You should laryngoplasty type 1 is nothing but, remember that laryngoplasty type 1 is medialization of vocal cords. So I'll tell you, I'll go in detail of the laryngoplasty in the next class, but right now just remember, I told you this will be in the paramedian position, right? So there is a gap here. Normally the vocal cord is supposed to meet both together. I mean, they have to oppose each other. They are in the, I told you, normally they'll be in the intermediate position here, and then when there is adduction, they come close together, and in abduction they separate apart. That is while breathing. So what happens is, now let us say this is in the paramedian position, there's a large gap here. So the voice will escape. Obviously, when he's trying to speak, there'll be a loss of voice. So there'll be improper voice. Now, what we do over a period of time, I told you that you wait for period of 6 to 12 months. You see whether this is compensating or not. If this is not compensating and still the patient has a breathy voice, so what we do is we medialize the vocal cords. We medialize this vocal cord in the paramedian position. This is okay, but in the paramedian position, we medialize the vocal cords, so that how do you medialize is I'll tell you in the next class. But you medialize this paramedian here, so that it meets here, so that the voice function, the breathy voice is improves over a period of time. So that is type 1 thyroplasty, remember that. And this Teflon injection into the thyroid, to again it stiffens the, so if you inject the Teflon in this paramedian position, it stiffens. So what happens, it comes little closer to this other vocal cord. So that also might help, but Teflon injection now we don't recommend. We go for the type 1 Ishiki thyroplasty type 1. Okay. Now coming to the in case of okay, now coming to the bilateral abductor paralysis now. So both I told you there are bilateral abductor paralysis, which is now let us say thyroid surgery has been done. We have someone has excised, the surgeon has excised both the recurrent nerves. Okay. Now what happens? Now all the intrinsic muscles of the larynx are paralyzed. The vocal cord lies in the median or paramedian position due to unopposed action of, again. So remember, unilaterally what happens? Cricothyroid is functioning. Only we are talking about only the recurrent laryngeal nerve here, right? So both the recurrent laryngeal nerve has been sectioned off. So now what nerves will be what muscles will be acting? Cricothyroid on both sides. What is cricothyroid action? It's adduction. So we'll bring the vocal cords adducted. Now what happens? You see, if the vocal cords normally, when you respire, when you take air in, or when you take when you breathe out, the air from the lungs escape to the vocal cords. Now, since that, now air also has to enter through the vocal cords into the lungs, right? So now, when due to the unopposed action of the vocal cords, the cricothyroid muscle, these are both adductor. See, there is no gap here. So there is slight gap, but there are large. You can't see any gap here. Now, what happens is there will be whenever there's inflamed larynx, or in even normal people also, even in normal means, I mean, when they are affected, there might be breathlessness, there may be stridor. So you have to go for it. You have to go for a tracheostomy, because they might land up in a dyspnea leading to breathlessness. So you can't intubate the patients here. You can't see, because you have to push through the vocal cords. So intubation is very difficult. So what you do, you have to go for a tracheostomy. In long-standing cases, see, if let us say if at all this thyroid surgery has been done, and then both the recurrent angina paralysis, both the recurrent angina nerves have been affected. So in these cases, there is no improvement. So in this, the patient has to go for a long. I mean, you have to look for a long-term solution. Now, what is the long-term solution here? You can't leave the patient here like this, because whenever there's infection, let us say there is a small opening here, so air escapes when the patient is normal. But when he walks, when he exerts, this won't be enough. So there he needs a lot of air. So there will be breathlessness, there will be dyspnea, there will be stridor. So in that case, what you are going to do? So one is tracheostomy. So whether in a long-standing case, you have a choice. You either you go for a permanent tracheostomy, if you where the patient is willing, you go for a permanent tracheostomy, and the patient breathes to a stoma over lifelong, he won't have a voice. That has major problems. There will be cosmetic problems. He won't be able to converse. There's no speech here. Only there is protection of the only airway. Only thing is that he can breathe through this tracheostomy. Now, whereas there's a choice, you can do a lateralization procedure named as type 2 thyroplasty. There's a Sudhakar, నేను క్లాస్లో ఉన్నాను చెప్పు ఏమైంది ఓకే ఆయన ఇప్పుడే వెళ్ళిపోయారు సుధాకర్ ఇంటికి వెళ్ళు లేకపోతే ఫోన్ చేయండి Okay, in case of lateralization procedure type 2 thyroplasty, what we do is we lateralize the vocal cord. See here, I'm just scrolling down here. So I told you type 1 is medialization, right? In this case, we medialize the vocal cord so that they oppose each other. Now we need airway. So we lateralize the vocal cord. We put the vocal cord which is abducted. Both vocal cords are abducted here like this. So what we do is we lateralize it. How do we lateralize this? I'll just tell you in the operation part. Now just remember that we lateralize this vocal cord, the affected one, or the both. So one vocal cord we lateralize, it is enough. There will be an airway. So let us say one vocal cord, what we do is we lateralize it. Okay, we lateralize the vocal cord. That leads to which leads to there will be an airway now, right? Or there are other procedures, that is type 2 thyroplasty. There are other procedures. Now let me explain this. This is the transport coordinate, also known as Kashima operation. So what we do is we just take laser. Okay, we just excise here. We excise here. This is the vocalis muscle here. If you can see, this is the vocalis muscle here, and see, this is where the vocal cords, you'll have the arytenoids, you'll have the vocal parts of the arytenoid here. We just put a we just excise this area so that air escapes from this area. So remember that this is a Kashima operation is for you just for airway. So when providing airway, okay. But we go for the this is type 2 thyroplasty is more simpler and more easier to perform. So whereas in the reinnervation procedure, there has been other where the posterior arytenoid is you know that these vocal cords are in adducted position. That is because of the unopposed action of the cricothyroid muscle, right? So now what we try to do, we give an action, we can give a muscle which is an abductor. So we try to innervate the posterior cricothyroid which has lost the nerve supply by innervating by another nerve, either using a nerve muscle. So there's a sternohyoid muscle in the neck, which is an which is an strap muscle. It has its own nerve supply. We try to take the sternohyoid muscle and connect it to the we suture it together up to the posterior cricothyroid muscle, so that that nerve supply of the sternohyoid may help this nerve to be active, so that the posterior cricoretinoid might function, so that leading to abduction, so leading to better airway. So, or you can directly give a nerve supply to the you can directly implant a nerve to the posterior cricoretinoid. So these are the reinnervation processes. Okay. Or there is a partial arytenoidectomy, where you remove the arytenoid and the part of the vocal cord. See, this is how you provide an airway. So partial arytenoidectomy. Okay. So only the vocal process of the arytenoid is updated here. See here, the vocal cord process. This is the vocal cord process, and this is the lateral process of the arytenoid. Now this part has been taken off, and a little bit see. So now you can see the airway. Air can enter now. You have an adequate airway. Now coming to the paralysis of this, I think I'll just stop here because I don't want you to get confused for the recurrent angina. I want you guys next see JP and Venki, please please tell your classmates or your colleagues, whatever it is, that please be thorough with the recurrent angina. Next session I'm going to ask you questions on muscles of larynx, the nerve supply of larynx, and the recurrent angina paralysis of unilateral bilateral. I can go directly into superior angina paralysis, but I think you'll get confused. So I am giving you time to learn. So next class will be on Friday. I think I suppose I'll take on Friday. So whenever is my next class, please be ready that please make sure that you read all the muscles of larynx, the nerve supply of larynx, and the recurrent angina paralysis. Up till this, I want you to understand, read, and next time will be at least 15 minutes. I'll be covering everyone. I'll be covering almost everyone. I'll be asking questions, so there won't be any randomly. I'll be picking at least 15 to 20 people at least. So please make sure that you read, because next time onwards, if I'm going to ask you a question, you're not able to answer one or two questions, I won't be giving the attendance, because if you want to progress in larynx, the thing is that you need to understand these nerve supply and this. So make sure you read that. So that concludes this session today. I'll stop here. I think attendance will be taken by the Rajesh. Attendance is for Rajesh. Ulena? ఎవరు యాబ్సెంట్ వాళ్ళు పెట్టేస్తారు. ఇమీడియట్ గా వచ్చేసి